so care of a child with respiratory disorders. Our cute little kid here. Alright, so when looking at physical and anatomical differences between children and adults, so they're tiny people, right? They're tiny humans, they're tiny adults. We have to treat them a little bit differently. Their nasopharynx and nares are smaller. They have a really small oral cavity in relationship to their tongue. Their tongue is really large, which basically what that means is anytime their nose gets clogged up with snot, anytime they get a stuffy nose, swelling up there, anytime they have any swelling in their tongue, it's going to make it harder for them to breathe. Their epiglottis is long and it's floppy. It's very prone to, when they get some type of upper airway infection or upper respiratory infection, that can swell easily and cover that airway. When you're looking at lymph tissue, it grows very rapidly in childhood. This is why you see a lot of kids that have problems with obstructive sleep apnea, with tonsils, swelling, and things like that. Tonsillitis generally starts to atrophy by, I want to say 10 to 12, between 8 and 12 years old. That's just a fun fact for you. And that's why after that time you don't see a lot of kids needing like that tonsillectomy and amyloidectomy, okay? Because if they haven't gotten big enough by then to cause a problem, they're not going to, okay? Your thyroid, cricoid, and tracheal cartilages are immature. So when you look at kids, they have the cartilages and they have the cartilage rings and things like that, but they're immature, so they're not as strong when you're looking at that, so it makes the airway more prone to collapse. Same thing with the muscles. Fewer muscles are functional in their airway. Their larynx and glottis, because they have a smaller airway, they've got a shorter. When we're looking at upper airway, it makes it higher in the airway. So anytime it's swollen, it can cause problems, airway obstruction. Their chest wall is more pliable, so they're not as easily able to compensate. When you're looking at their chest is relatively round at birth. They're kind of barrel. When you look at small, babies and toddlers and things like that, they're kind of barrel-chested. It generally equals out about age 2, but their chest is relatively round at birth. Their ribs are more horizontal, and with all of those things, with that relatively round barrel chest and those horizontal ribs, they're abdominal breathers. Okay, so what this means for you when you're assessing a kid, if they're an infant or a small child, you may be wanting to look here when you're assessing respirations and things like that and counting respirations versus thoracically. Okay, so generally, girls and boys, both abdominal breathers up until about age 7, and you see girls shift to a little bit more thoracic pattern and boys kind of stay in an abdominal thoracic. When you're a child, like when you're assessing that and things like that, if you have trouble listening, counting, things like that from the room, one thing you may want to do, especially if your child is calm and, or sleeping and things like that, is just put your hand right here, and it'll help you count that respiratory rate. Diaphragm's more horizontal, so we don't have that, when they get, you have babies, they're crying and things like that, they suck a lot of air in that stomach, and that's just going to push up on that diaphragm, push up on the lungs, and make it harder to breathe. And then we've got that large amount of soft tissue along the airway. So basically, as you've assessed kids and listened to the simulators and things like that, you've noticed that we've got faster heart rates and respiratory rates in kids. These are not the I'm 60 and feel like I'm pulseless. Elderly folks, we do have some teenagers like that. But so the result of that, they already have decreased chest excursion. They have a faster respiratory rate, so they're already working faster to breathe at their baseline. Okay? So anytime you have stress or respiratory infection or things like that, it makes it more difficult. Okay? When you're looking at infants, they are obligatory nose breathers. Okay, and that doesn't mean that they can't breathe through their mouth. It just means that most of the time they're eating or something else, oral fixation-wise, and so they're breathing through their nose. And so if they've got a stuffy nose or things like that, that makes them more prone to respiratory distress. Okay, questions about any of that? For nose breathers, generally, I think about 6 minutes, 6 to 9 minutes. just means, like, if you're putting oxygen or something on an infant or a small child, and especially with RSV and some of the things we'll talk about in a little bit, and they've got copious nasal secretions and it's not, a nasal cannula is not going to help unless you suction that out first, or bulb suction, and make sure that their nasal passages are clear. Because, like, as an adult, we've got a stuffy nose, and yeah, we don't feel good, and it makes it harder to sleep and breathe before laying flat and things like that, but we can still breathe because we've got a really large oral airway. Alright, so quick review when we're looking at respiratory emergencies. So we've got this whole continuum that we have respiratory distress. So we've got that increased work of breathing, and we have adequate gas exchange. Okay, so they are able to compensate. When we look at kids, if you're looking at adults, for example, you see them and they start to go downhill and have a problem. It's kind of a staggered step thing. You have time. Kids will sit there and compensate and play and play and play and play and play, and then they will crash. Okay, so you just need to watch them closely, and they need to have intervention early. You can't just say, oh yeah, they're still playing, they're still fine. My kid was wheezing, stridorous. Mother-in-law fed him oatmeal and milk with croup. Had to go and have her see makeup and things like that. She's like, but he's playing. Yeah, he's playing. He's a kid, but he's not breathing well. So they're still compensating in respiratory distress. With respiratory failure, they are not compensating. They are unable to maintain adequate oxygenation throughout. Okay, and then respiratory arrest. Y'all had fun with cardiac and respiratory arrest last week, right? Did your patient survive the second time around in code sim? Good. All right. So what do we do to manage respiratory distress? We want to support the compensatory efforts of the child. Children are very resilient. All right? As we said, they will play and play and play. They will do what they need to do. Their bodies will do what they need to do whether they know it or not. All right? Most of the time with this, kids will get in a position that they call a position of comfort. That may be tripoding, so they may be leaning forward onto something. If they're sitting down, you know, they're going to be leaning forward. They're going to jet their chin out and help open that airway open. When you're looking with infants and things like that, when you hear grunting, which is an ominous sign in infants, it's because they're trying to peep themselves. They're trying to hold their airway open as they breathe. Okay? So you're going to support whatever compensatory efforts the child is making. One of the things you can do, elevate the head of the bed. You can also use a jaw thrust maneuver if you need to help open that airway. If you're having to continually do that, your child needs to go to the ICU. We had that happen one semester. We came in on report, and they kept saying, but he's breathing. Well, yeah, the charge nurse was standing in there jaw thrusting him. Yeah, he needs to go to the ICU and be intubated. So, elevate the head of the bed, pull your patient up. You may need to position something behind your neck to help open that airway a little bit. Adults, it's kind of like a bendy straw. You can sit there, extension, flexion, and all that, and your airway is still going to stay open. With infants and small children, it's kind of like a coffee stirrer. If you bend it over, it's going to clamp off their airway. So you don't want to hyper-extend or hyper-flex their neck. Whatever position of comfort they're in, if they're sitting in mom's lap and they are happy, we're not going to take them out of mom's lap and yank them over to the bed and start sticking them with IVs. Okay, we're going to leave them there, put the oxygen in there, have the parent help, things like that. Whatever sources of stress, as we were talking about, and we want to cluster care. As you kind of saw at those of y'all that were in Head Start and doing Finger 6, you know, they can get really distressed with things like that. Just a little bit, huh? And so whatever we're having to do, especially if they don't know us, we want to cluster our care. So cardiac and respiratory, that's a big deal, is making sure that you go in and get everything done at one time and allow them time to rest. Okay. Suction as needed, oral or nasopharyngeal suction. Humidified oxygen. So there's a lot of literature out there that can say, well, it doesn't do a lot, it may. The biggest deal is if they're in respiratory distress and you're putting dry air down an airway that's already inflamed and things like that, especially if it's high flow, it's going to irritate the airway further. So humidified oxygen can help soothe that a little bit and help it not be as inflamed. For those that have been crying or in respiratory distress for a long time and sucking in air, and things like that. Their abdomen may be distended, and as we talked about, that makes it pushes against the diaphragm and makes it harder to breathe. So they may need a nasogastric tube for venting for abdominal distension. And so, and we already talked about respiratory distress can progress to how it progresses to respiratory failure in kids. This is a good picture of a kid tripoding. So you can see they're sitting forward and they've got that mouth open and they're knuckling forward. So moderate respiratory distress, you kind of see that kid mouth open, leaning forward, eyes wide, not looking good, pale. Nasal flaring, if you've never seen it, I have a video of that in a minute. And then you see from that wide panicked to start, we're looking sleepy, we're looking a little more stressed, and that's when you're going to start to see that decreased level of consciousness, and you're going to go into severe respiratory distress, and that's a sign they're about to progress to respiratory failure. So you can kind of see the progression there. They're opening their mouth wider, trying to get as much air as they can. They go from, we're irritable and we're panicked, and then we're just kind of sitting there, and then we're starting to lose. Decreased level of consciousness. Alright, so one of the other things you're going to see in respiratory distress is retractions. And with kids, because of their chest wall is not as thick and things like that, you can see them really well, whereas you may not see them as well on adults in the past. It's important to note where the location is and the severity when you're assessing for retractions, because it can kind of tell you what's going on with the kid. For upper airway obstructions and things like that, when you look at croup, when you look at foreign body airway obstructions and some of those things, you're going to see that more supraclavicular and suprasternal, and some of that substernal. They'll be pulling in right there. You'll see kind of a triangle pull in. Versus when you're looking at lower airway, asthma, pneumonia, things like that, you're going to see these intercostal retractions. Okay? And then mild, moderate, and severe. Are they just, pulling in a little bit, or are you literally seeing all of their ribs as they're sucking in air, or do they have a big gaping hole kind of substernal as they're, breathing? So the reason we do the respiratory lecture first versus cardiac and things like that is the most common pathway when you're looking at cardiopulmonary arrest in children is respiratory failure. Okay? So it can occur due to upper or lower airway obstruction. So upper airway obstruction, foreign body, they swallowed something they shouldn't and it's swollen, their airway swollen. They have croup or some type of bacterial or viral infection that is causing their upper airway to swell. Lower airway obstruction, that's where we're looking at asthma, pneumonia, respiratory syncytial virus. Things, inadequate respiratory effort. So that can be, several different things. Either they have maybe they're in surgery and they came back and they still are a little bit sleepy from anesthesia. Okay? They could be on some type of opioid, narcotic, or PCA morphine pump that's making them sedated. If you have a kid post-seizure that's in that post-ictal phase and they're not able to maintain their airway, those types of things. That would be your inadequate respiratory effort. Some type of, spinal trauma, things like that. Pulmonary abnormalities. So that's when you're looking at, do they have some type of structural malformation in their airway, like tracheomalacia or something like that, where they either have a malformed airway or some other type of tumor or things like up in their airway that's causing to make it harder to breathe. Other things, pulmonary abnormalities with muscular dystrophies and things like that, like Duchenne's. Over time, when you're looking at all the muscles, they start to do this. They get like a musculoskeletal type of scoliosis, a neuromuscular scoliosis. And what it does is they're not holding their ribs up, and so their diaphragm and things crunch down, and it makes it harder for them to breathe. So the thing about with scoliosis, you don't just have that S-shaped curve, you also get a rotation of their spine, and remember your ribs are hooked onto your spine, so they start to turn, and it can actually crunch kind of on their ribs. So some of these kids with spina bifida, muscular dystrophies, cerebral palsies, and things like that, where they either have weakened muscles to support their skeletal frame, or with like cerebral palsy, they have spasticity, so they're constantly holding them in a certain thing. You'll see these kids develop scoliosis. And as it starts to crunch and cause compression on their lungs, that's why we do spinal fusions sometimes, to straighten them up and make it easier for them to breathe. Okay, so that's the pulmonary abnormalities. So if the things that we try to do early on with kids, I know a lot of times we talk about, with adults, it's not a big deal to do a procedure. We just, we start another IV if we want, we practice, things like that. With kids, we don't do procedures unless we have to. And there's times that you're like, well, nothing's going on, the kid's not crashing, it's not doing that thing. That's because some nurse has done a damn good job of assessing and intervening earlier on with this kid, so they didn't crank and crash on you, and that's a good thing, all right? So if we don't manage the respiratory distress and it progresses to respiratory failure, none of those passive airway, adjunctives work, nasal cannula, non-rebreather, things like that, you're going to have to do some type of active ventilation. You may have to bag them. For example, if they're post-seizure, we don't automatically intubate them. You may try bagging them a little bit longer till they wake up, versus if you have to turn around and intubate them or ventilate them. Okay. Occasionally with some kids, they will try something like Bi-pap or CPAP in the interim if it's more of like an obstructive sleep apnea or something post-surgery. They may have some other type of pulmonary abnormality like muscular dystrophy or something like that. So red flags with kids.
Do you use like a Bi-pap or CPAP? Do you use, are they hooked up to moisturize the air?
Yeah, they can. Yeah, there's different ways they can hook them up. Alright, so early signs with kids. What do you start to see? They start to get restless and they start to get irritable, and your parent tells you that they're not acting like themselves. Okay? That's why they brought them in. You will see them tachypnic and tachycardic, so respiratory rate's up, heart rate's up. Remember, if your infant or child has a respiratory rate of greater than 60, they're at a risk for apnea, secondary to having that increased work of breathing and that buildup of carbon dioxide. We do not feed children orally if they have a respiratory rate of greater than 60, because that makes them also at risk for aspiration, because they're already trying so hard to breathe. So if you're looking at a kid that's like that and they're going to be that way for a continuous period of time, if they have like a cardiac defect or something like that, that's one of the times that they'd put like a nasogastric tube in so that they could do secondary types of feeds. You'll see increased respiratory effort. So there's the retractions, nasal flowing, the head bobbing, things like that, and grunting. Late signs. You start to see the respiratory rate's going to go up. Then as they start to decompensate, the respiratory rate's going to drop. So if you haven't done anything to intervene with your kid and their respiratory rate was 58 and now it's 14, they're not getting better, they're worse. Right? So you'll see a decrease in respiratory rate, or you'll start to see that irregular pattern. So like with DKA, you start to see those Kussmaul's respirations and things like that. Diminished breath sounds. So for things like asthma, as they start to clamp down on those lower airways and those bronchioles and your bronchial tubes and things like that, the air will not move as well through them, and they can get so swollen that they're just not moving air. And so you will hear diminished breath sounds. Start to see drowsiness or decreased level of consciousness. You may see changes in their skin color. So, they may be pale, they may be cyanotic. Remember, if you're darker skinned, they may look gray or ashy versus blue. You may have to look at their mucous membranes and things like that to kind of tell if it's hard to tell. They may be, they'll come in, they'll be diaphoretic, they'll be sweating, things like that. And then you start to see apnea and bradycardia. All right, so if they're bradycardic because of respiratory distress, it's a very late sign. All right. So a big deal. The quieter the child, the greater the cause for concern. And what that means is if they're quiet, you remember kids around, y'all saw them that day, we assessed them, right? They were hitting the ceiling. All right. So if they're in respiratory distress and, they were talking, or all of a sudden they're not able to talk, if they're not able to cry, if they're unable to swallow, and with that what you're going to see is, copious drooling and things like that because they're not able to swallow and manage their secretions. If the respiratory distress is worse, if all of a sudden they were fine and they have an acute onset of drooling, that means they may have an epiglottic or supraglottic obstruction. Okay, so if any of that occurs, you want to get help immediately. All right, so if your child was wheezing or stridorous, and you raise the head of the bed and you walk out of the room, and all of a sudden and you come back and they're not doing that anymore, and you haven't done anything to treat the wheezing or the stridor, that's bad. Okay, all right. So just to review, when we're looking at oxygen delivery methods and what that means, one of the things you'll see with kids is you may see something called blow-by oxygen. Okay, so the first we're going to talk about passive. And so when we talk about passive oxygen delivery, what does that mean? They're able to maintain their own airway so they can breathe in the oxygen on their own. Okay, so what we see with blow-by is occasionally, so somebody's post-op or you've got a neonate or something like that and you need to give them a little bit of oxygen, but they don't need a nasal cannula, they just need something for a second, they will do something called blow-by. And it's either hooked up to oxygen and it's a piece of corrugated tubing, or it's just like a face mask set to the side. It is not on their face. Right? But it's unreliable. You don't know how much oxygen is being delivered because it's mixing, with the air. And half the time, if the kid's sedated post-op and they've turned their head, you're oxygenating their ear or their eyeball. So it's, that's the thing. But you may see it, post-op. And then other than that, you'll see nasal cannula, and it can deliver anywhere from a quarter to up to like about 4 liters of oxygen. Anything above that on nasal cannula is considered high flow. So a quarter to 4 is low flow nasal cannula. Anything above that is high flow. When it's high flow, it needs to be humidified because if not, you're going to totally irritate those nasal passages. What you will see with that, you may see vapotherm or something else called optitherm, O-P-T-I, or optiflow, optiflow, O-P-T-I flow. And that's going to be your 5 to 8 or 5 to 10 liters of heated humidified. So that's your oxygen nasal cannula on steroids. All right, pretty much. So high flow. Then you have your simple face mask, which is going to be your 6 to 10 liters. One of the things they can do with that simple face mask is they can also hook up what's called a venti. To make it a venti mask or a venturi mask is they hook up a little flow meter to that simple face mask. And what it can do is, so we know the oxygen concentration of room air is what? 21% or 0.21. So one of the things you can do with a venti valve or a venturi valve is you hook it up and it can turn anywhere from like 23 to 40, 45% oxygen. Because it just is what it does is it blends. It blends the oxygen with the air. Okay. So it's something they can do in the middle. So then you have a non-word breathing mask, and that's going to deliver what they say is 100%. But a lot of literature says it really only delivers about 60 to 80. But we're going to call it 100% non-word breather. All right. Why do you think that it's not totally delivering 100%? Anybody? We have certain sizes of masks, right? And we can tell all of us are, different sizes in here, but there's one adult mask. And so it's not going to be as tight where it needs to be. It may hang loose. So you're just not getting the full on the face. Okay, and that's generally why. All right, so all of those are like passive. They have an airway. They're maintaining their airway. So then these are going to be something that's going to be that you actively have to do. So we've got your bag valve mask. Where does that mask need to fit? How do we know what size? Bridge of the nose to where? To their chin. It needs to fit firmly around. All right. How do you know your ventilations are effective? You're seeing equal chest rise and fall. Okay. Then the other thing in the middle is the Bi-pap and CPAP. A lot of the time this is more used with obstructive sleep apneas, floppy airways, and things like that. But what it's going to do is it's going to help with that positive end expiratory pressure. So it's going to keep that airway, open so they can breathe out more and get rid of that CO2. And then if you have to intubate or ventilate them. And we don't go a lot into that because y'all talk about vents in adult too and have enough fun with that there. All right, same thing, same concept. All right. Okay, so here's a picture of Blow-By. You see the kid also has a nasal cannula on. What else do you see there? You're seeing that substernal retractions. Little bitty bit of nasal flare. It's harder to see on her, but she's also, you see her bobbing a little bit and opening her mouth. Leaned against mom. All right, what do you see about that that's concerning? Heart rate's 154, that's high, because, I would say that kid probably, normal heart rate, say 120 or so. It's probably at least 20 to 30 above. What else? Possibly a little bit, but, we're not as worried about that, because with kids, when we look at blood pressure, we're more worried about that with shock, because it would mean they could be, decompensated or hypotensive shock, but it's probably going to be up a little bit anyway if she's in distress. What else? Pulse ox is 100, but so she's not getting 100% oxygen, but she may be. She's still in distress, even though, what is the pulse ox, what's it measuring? It's looking at perfusion, so just because you're perfusing doesn't mean that you're oxygenating necessarily well. And the deal is with children, you're looking at small capillary beds. So if they've got little bitty fingers and toes, it's real easy to oxygenate capillary beds. So a better place to, check that is more centrally. So when you're looking at, for example, capillary fill and things like that, it may be more accurate to do it more centrally, like on a thigh or a groin area, somewhere on their abdomen, than if you're doing it peripherally, because they may look like they're perfusing here and they're truly not. All right. Plus, with kids, they're doing all of this and it's not going to be accurate. I've had a parent post-op decide she was tired of hearing the alarm go off and put the pulse ox in her own finger. So I've had it off and checking the air, oxygenation and things like that. So you're concerned if she's pale and she's in respiratory distress that her pulse ox is 100, so we would want to look at our kid, right? Or as Mr. Freed sometimes says, don't look at the monitor or the idiot box, look at your kid first, right? All right, what else? Yeah, that's what it's looking at that. Temp's normal, 37's 98.6. We treat at 38.5 or 101.5. So if you remember those two numbers, 37's 98.6, 38.5 is 101.5, when you start to look at your kids in the hospital and start taking temps and things like that, as you get to, oh wait, I'm 39.5 or I'm 40, well that's 103.5, 104. You start to get in your head, that's not good, right? Whether you convert it or whether you have the ring. Okay.
You said that one more time.
What, 37? Is 98.6, 38.5 is 101.5. Okay, what do we see? This one's got good nasal flaring, you can see. You're seeing some abdominal breathing. You're hearing that. So they've got grunting. That's grunting. And you see how that baby, when you're looking, pause this real quick. Your babies have like no neck and things like that. So when we were talking about trachs and some of those things, this is why they would use certain types of trachs versus another, because they have like no neck. So they're already crunching down and making it harder. So that baby would probably do better to be elevated. Alright, so what else do you see up here? Heart rate's 155. Which, I mean, they're an infant, so it's a little high. But what else? Respiratory rate? It's high. SATs are 94. And we know with kids, basically, they've got virgin lungs, so they should be 100. They haven't been exposed to all the fun stuff we have. So they should be 100, so the SATs are 94. And the blood pressure's, fine for that. All right. So these are the videos for pediatric pals and pairs, so just to give you all an idea of what's on. You'd watch it. I mean, they might have some type of viral. When you're looking at viral versus bacteria, if it's really, really high and it's shot up really fast, you're more worried about bacterial than viral. 37.4, you'd watch it. So when you go in the morning, some of these kids may be cool, because they've been still, they've rested overnight. You may need to cover up and go back and retake their temp. We're not going to try to temp that's like 35.6 or 35.8. We know it's not correct. Same thing with that. The kid, obviously, they may be on a warmer. They may be a little warmer than that. You may need to uncover them a little bit. It's something you'd watch, but it's not necessarily. Alright, so you can pull out your case study for the first one. Give you all a minute. Alright, so I'm just going to start reading it. So Helen's a 10-month-old girl. She lives with both parents and 2 siblings. Mom just went back to work because of financial reasons. So Helen, her 2-year-old brother, and her 3-year-old sister are all now in daycare while both parents work. They were all breastfed and weaned to the bottle at 7 months of age. Helen's currently bottle fed. Okay? The family lives in a middle-class neighborhood, and Dad is a heavy smoker and has been for the past 10 years. Last week, Helen had an upper respiratory infection, or a URI, after being exposed to a child who is sick in daycare. Because everybody has to work, so they send their kids sick to daycare. Alright. 5 days later, she was seen in the physician's office for a temp of 38.3. So, say 101.2, 101.3. She was fussy, she had a decreased appetite, and was pulling on her right ear and crying. And that's very, characteristic of otitis media or an ear infection. Because they're not able to tell you always and express what's going on and what's hurting, but they will be pulling at that ear because it hurts, and they will be fussy. When they went in and looked, her red tympanic membrane was bulging. It was red and opaque with a small amount of purulent drainage. So you can see that picture. Doesn't look very good, does it? Alright, so overall, when we're looking at otitis media, what risk factors out of that case does Helen have for developing acute otitis media? Bottle fed, so what are we concerned about with bottle feeding? That they're drinking laying down and that they're bottle propping. What else? So exposure to cigarette smoke. What does cigarette smoke do? It irritates. It irritates those mucous membranes, and it irritates the lining of their ear canal. So secondhand smoke, we're already looking at kids. They already have an immature immune system. The characteristics of the eustachian tube, so it's relatively short and horizontal. So stasis, think stasis, and it's prone to collapse. So when you have any type of negative pressure build up, that's going to make it collapse. Daycare attendants, because no matter what you do, they're all going to, snotty nose, they're going to touch their friends, they're going to, lick each other, whatever they do at daycare. We talked about bottle feeding probably. Alright, so recent relationship between Helen's recent enrollment in daycare and her condition. At home, they're not being exposed to as much as we talked about. Everybody sends their kids to school or daycare. They tell you now you can't send your kid to school if they have a temp over 100. What a lot of people do is give them Tylenol or Motrin and send them to school anyway, which drives me insane because my children then catch it and I do not send them to school if they have a fever. Anyway, so you have increased exposure to other children, very close contact, lots of cross-contamination. You could follow them around all day with a Lysol wipe, but they wouldn't do you, any good. They're faster than you are, and there's more of them than you. You are overwhelmed. So you have cross-contamination and an immature immune system. It's very hard to clean that gunk out of Legos, things like that. Yeah. So, what's the relationship between the upper respiratory infection and the development of otitis media? Right, they're already irritated, so they're already we're talking about immature immune system, they're already, at risk. So when we're looking at children, 80% of infections are respiratory. They account for most hospitalizations in children, especially with chronic things like asthma and things like that. So 80% of infections are respiratory. Most of them are viral. You've got those immature eustachian tubes. They easily collapse. When you have that collapse, you have that fluid buildup. Things are not draining in the ear. That negative pressure, anytime anything sits, that bacteria has a field day and grows. So, my kid last year ended up with pink eye, but she'd had an upper respiratory before. And so I said, here's what she's done all week if she's done those. So, I'm like, it's the same thing, that's what they got it. So how does passive smoke increase the risk for otitis media? We talked about that. It irritates the eustachian tube, so you get that inflammatory response. Now, that's pretty much what it does to the whole respiratory tract as well. You saw the new law that now you can't smoke in the car with kids under, 12 or 13. You're not allowed to smoke in the car. There's a law that you can't smoke in the car with children, or they can ticket you. It's very recent. That's why I can't think of the age range. If it's 18, under 18. So, of course, if they smoke in the car when the kids aren't there and then the kids get in it, it doesn't matter. Yeah. And my father-in-law is a heavy smoker, and he'll go in and out, but the kids come home, and I'm like, you need to be deloused. So, yeah. Okay. And they come home, and I'm like, okay, you need to be decontaminated. My mother-in-law's like, oh, wash their clothes. I'm like, opening the bag. Are you smelling smoke? Yeah. And he doesn't smoke around them, but, and now he uses the vapor, but it hasn't been out long enough for them to know the side effects of that, and some say the chemicals with that are just as bad, so. Especially when you have kids with underlying respiratory, or allergies or things like that. Did you get it? Okay. All right. Primary treatment for acute otitis media. What do we do about it? A lot of times it's wait. So if they are under 6 months of age, they may go ahead and treat them just because when you're looking at the whole range of things, they're more at risk. You don't want to have hearing loss issues. So they may go ahead and treat them because it's harder sometimes to diagnose with little bitty kids. So they may go ahead and treat them with antibiotics. But generally, over 6 months of age, it should resolve itself. They will say, hydrate, give them Tylenol, and things like that. But what happens a lot of the time, you've already waited 24 to 72 hours before you've taken your kid into the doctor. So they'll go ahead and give them antibiotics, But generally, it's wait and see first if they're over 6 months. After that, you take your kid to the doctor, or they'll say, oh, here, if they're not better in 3 days, take this prescription. What do most people do? They go ahead and fill it, give it to their kid. They don't wait. So you see a lot of over antibiotic use. Because if it's viral that's causing it, it's not, It just depends. A lot of times, so first line, they generally give them oral antibiotics, which would be penicillin, so amoxicillin. Because amoxicillin is pretty much, and a lot of penicillins are prescribed first line and overused, you see it doesn't always work. So if amoxicillin doesn't work and they're still having issues, they will go back and as a second line use Augmentin, which is amoxicillin and clavulanic. So after that, occasionally they may use Omnisaf or something like that. And if that doesn't work, occasionally they'll bring them in and do Rocephin shots, but you have to go in like every day for 3 days or something like that and do a Rocephin shot. So they may give them, now they have more antibiotic eardrops that they may try if they're having continual issues, but a lot of times they just give them eardrops for pain, and then whatever they're going to give them for fever. If they continue to have infections, they may try to do a myelongotomy with tympanostomy, which is basically it's putting tubes in their ears. And what that's doing is that's going to keep that eustachian tube open. There's a whole other set of fun issues with that because you're not supposed to immerse them in water and all kinds of fun things. But if they have recurrent infections, they're worried about that. Chronic recurrent infections, there's also a risk of conductive hearing loss. We have a friend, her little girl has had to have multiple ear infections, and she actually ended up having to have like a skin graft flap and all this stuff because she keeps getting like a fungal type infection then in her ear. It's very weird, but her mom said she wrote something on her back to school thing. If she could have any wish, she could, and she's like that her ear would be better. So it was kind of sad. But she's starting to have some hearing issues because of it. So, alright, so Helen was given amoxicillin for 10 days. On the 9th day, Mom brought her back because she's presenting the same way, still having issues. So they prescribed Augmentin 400 milligrams every 12, and she weighs about 20 pounds. So what's the safe dose of Augmentin if it's 90 kilos per day for her weight? Whose brain hurts right now? Here, I'll just tell you. Alright. So we're going to convert our pounds to kilos. It's going to give us about 9 kilos. You're going to have 9 kilos times 9. It's going to give you 810 per day, and you're going to divide that by 2. So 4 or 5 per dose. She's getting 400. So we're good. Now, it's right around there. So be aware, if something's ever like low, like if you don't have a dose range and you just have a singular thing like this, if it's lower than the dose, this is obviously rounded and it's the pharmacy and we've checked and all that kind of stuff. But say your range is 200 to 400 milligrams per day and they've ordered a dose of 100. That's going to be 100 that's in there. They don't necessarily say it's unsafe, but it may not be therapeutic. So, just be aware of that as you're looking at doses. Alright, who needs a break? Alright, why don't you take a 10-minute break? I have to take it off pause. Alright. Okay, so as we talked about, limp tissue goes rapidly in childhood, atrophies between 8 and 12 years of age. Biggest problem with that, inflammation of the tonsils. Most common cause of that is strep. Strep throat can be a very bad thing. You think, oh yeah, we'll just throw some antibiotics on it. But it can actually cause rheumatic fever and cardiac issues and renal issues with AGN or acute glomerulonephritis. that Jennifer Wilson will tell you all about. But yeah, so the most common cause of strep. We need to treat strep. It's a bad thing. All right. So symptoms of tonsillitis. You're going to have enlarged, swollen tonsils. What's that going to do? It's going to could make it hard to breathe if it's severe. It's going to cause difficulty swallowing. It's painful. With that, they're going to treat it with antibiotics. Most often, it's going to be some type of penicillin. And supportive care. So any type of respiratory, because of if they're working to breathe, you're going to see them diaphoretic. You're going to see them blowing off all of this. That's insensible fluid loss. Okay, if it's hard to breathe and they're not drinking as much, they're going to become dehydrated. So supportive care, one of the things is trying to hydrate them. Then you're looking at, pain management, things like that, pain and fever management. If it is continual, the antibiotics don't work. If they have multiple infections within a period, I want to say like 2 years, they will consider doing a tonsillectomy and possible adenoidectomy. Biggest things you need to know post-op nursing care. That's going to be the types of things that you will see about tonsillitis in Clexin testing is what do you need to do post-op and observing for bleeding. So they've done surgery. There's sutures back there. What kind of blood do you think that you might see as far as secretions and drainage? Brown, old types of blood. So if you start seeing bright red, bleeding, it's going to, they may have old blood for a couple days, but say a week later, you start to notice that they've got bright red, bloody drainage in their secretions. Okay? If they're swallowing frequently, and that means the blood's trickling down the back of their throat, so you're looking for frequent swallowing, or bright red kind of blood. What makes it harder? We don't want to give them any red or purple tinged fluids, no grape juice, no cranberry juice, no red jello. That's going to make it very hard to tell and observe for bleeding. And then no straws or things like that. What's a straw going to do? It's going to cause negative pressure. It's going to pop your stitches. It's going to pull your clots. Okay? Same thing with any type of dental surgery, anything like that. All right, so no straws. Pretty straightforward, right? Other things post-op, you're worried about swelling, especially with fair-skinned white folk like myself. More prone to swelling with oral and dental procedures. So occasionally they might give them some type of steroid to ice, like ice pack and things like that. Alright. Talk about croup a minute before we go to the croup case. So, croup. It's a fun thing. It falls along a continuum that they call croup syndromes. Some are viral, some are bacterial. We have, under the viral end of it, acute spasmodic laryngitis, so it's going to just affect the larynx, versus acute laryngotracheal bronchitis, or acute LTB. It is much easier to say. And that's generally what we consider traditional croup, is LTB. Okay? Bacterial, you have acute tracheitis in the trachea, or epiglottitis. Okay, which is your epiglottis. The reason they call these croup syndromes is all can present clinically with manifestations of some type of upper airway obstruction. So sometimes it's hard to tell what the cause of it is. Okay, so the acute spasmodic laryngitis and the acute LTB are viral. About 50% of them, over 50%, are caused by parainfluenza virus. Fun fact. And then you've got acute tracheitis and epiglottitis. You don't see a lot of epiglottitis anymore because of the Hib, or Haemophilus influenza type B, Hib's easier to say, vaccine. Those are going to be your two bacterial. So the top two are viral, second two are bacterial. When you're assessing croup severity, what you're looking at, is it mild, moderate, severe, or do you have impending respiratory failure? So if you've ever seen a kid or heard someone with croup, you don't forget those sounds. All right, they're very distinctive. So it's almost like a seal bark cough. And so with mild croup, they'll have that occasional barky cough, but they won't have stridor at rest, and you're not going to be seeing retractions. Okay. With moderate, you're going to have that frequent barky seal bark cough. You'll have audible stridor at rest, which is very, and we'll listen to some of it, but it's kind of like, because they're trying to pull air in. And you may see some mild chest wall retractions at rest, but they're irritable. They're not agitated. Okay. They've got the cough, they've got some stridor, but they're not agitated. Severe, they're starting to have more and more trouble breathing, so you're going to hear that prominent stridor with the cough. You're going to see the increased respiratory rate or tachypnea. You'll see marked retractions. They're going to be agitated, and they may begin further distress. As they continue to do this and get increasingly fatigued, they may not be coughing as much because they're just, their decreased level of consciousness. Okay, you may see cyanosis and lethargy and things like that. Okay, I'll show you all these first. All right. Is everybody awake now? Yeah. So you see the open mouth kind of leaned forward. You're seeing retractions up here. That's supraclavicular. Seeing abdominal breathing. Close. So he still looks happy, he doesn't look distressed, but you hear that stridor. He's just like, I'm happy. It's like, y'all leave me alone. I need to go to the hospital. I'm fine. Yeah, go back. Inspiratory. They're struggling to get air in. They've got swelling. A lot of times you'll see in y'all's notes, you'll see what's called the steeple sign, and it's because the airway is swollen and they can't get the air in. So like he was up where he was, and then he was like, oh. He could have had croup. You can see croup in any age. My son first had it when he was like 4 months old. As children get bigger and their airways get bigger, you're not going to see it as much because they may have the same virus like we do and present just with like nasopharyngitis or a common cold. Okay? Versus, with kids with smaller airways and more prone to swelling. So most of the time you're going to see these kids, young kids up to like 4, but you can see them up to 5, up to 5, 6, 7, 8, yeah. I think we already saw that baby. Oh, we already saw him. Come back. Oh, well. Alright, do that. Alright. Okay. Go back to your case studies. Alright, so during the early evening, 2-year-old Mary develops a strange cough and a crowing noise when she breathes in. Why do we think we're having a problem during the evening? Why do we notice respiratory symptoms get worse in the evening? They're worn out. They've been working all day long. They've been playing hard and everything else, and they have just, been compensating all day long, and they're tired. So Crowing noise, strange cough when she's breathing. She had a mild fever and a runny nose during the day. When she cries, the noise during inspiration becomes worse. So mom got anxious and brought her to the ER. What is the crowing sound during inspiration called? Stridor. Okay. What's the most likely cause? Some type of inflammation of the upper airway, airway constriction, or as we can call it, croup. Other signs common with croup. Retractions, increased respiratory stress. We see that. We hear that barky cough, that subbar cough. What signs would suggest that the stridor is becoming worse? Agitation, fearful countenance, increased respiratory distress, leading to decreased, when we're talking about severe, decreased OSD, sinuses, retractions, decreased respiratory rate or chest excursion. Main treatment of severe stridor. I really don't give this any other time, but with stridor. Yeah. Mm-hmm. Do you remember what it was? It's not albuterol. It's okay. Racemic epinephrine. Okay. Racemic, R-A-C-E-M-I-C. Epinephrine. Okay. It's a nebulized sympathiomimetic. And that's what it's going to do is help open up that airway. Okay, we give it for stridor. We don't give it for croup. We don't give it for barky cough. We give it for severe stridor. Okay? It's different than when you're getting like an EpiPen, IM, or you're getting Epi, IV. All right? It's specifically to help with that airway. The other ones are more systemic. Okay? Other interventions for croup. Thoughts? So you talked about steroids. Yes, they will give the kids steroids. The earlier on, the better, because it will help stop that inflammation kind of before it gets so severe. The recommended steroid is Decadron or dexamethasone. They say it is better than Orapred, prednisolone, prednisone, any other steroid, be it IV, IM, or PO, Decadron. Okay. You want to hydrate the kids, so if they can drink, you want them to drink. You want them to drink like clear liquids, things like that are easy to get down, not milk, not oatmeal. And then coolness, humidified O2 can help with that airway. Now, if I were to give this kid an IV, or if I could start an IV or give him an IV shot of Decadron, what are you worried about with croup? They're already creepy and barky cough and stridorous. They're going to go, woo! And that can actually shut their airway down further. So you just need to watch them. Just be aware with that. Because the racemic epi may have helped, but then when you go give them the steroid shot and they start crying, you're going to hear it some more too. The big things with racemic epi, it's going to raise their heart rate. It's going to make them very jittery. This is not something we would give them a prescription and send them out the door and send them home with. They need to have it in the hospital, in the care now, in the doctor's office, and they need to be monitored. Okay, you're going to want to watch them. The one thing about it is they will say it has like a rebound effect, that that's what you're watching for. And basically you're looking for them to possibly revert to their pre-treatment state. They may need more than one treatment. Okay. They're probably not going to get worse than that initial thing, but if they came in pretty bad, they could revert, to that. Mm-hmm. Yeah, if you're in like the ER or something like that, you're going to be there a couple hours. If you're in the doctor's office, after 34 minutes, they'll probably, if it's depending on the severity of it. Mm-hmm. So that's really what they're going to watch, because some kids have to be hot. Rarely, Do they have to be hospitalized with mild croup and things like that? They can treat it. They can give them some steroids at home. They don't have to have racemic epi. Okay? But with severe croup, you're going to see that. All right. We're talking about cool mist and humidified oxygen. If they're at home and they call you in the middle of the night and they want to know what they can do, put them in the bathroom, turn the shower on high so it steams up the bathroom. Use the humidifier. A lot of times you're going to see it this time of year in the fall and the winter. I know we're in Texas and it's 95 degrees in December, but occasionally, we drop below 50 degrees. But if it is cold outside and you walk outside with them, that blast, that cool air will feed those airways, so you may not hear it as bad. Stick their face in the freezer. Yeah, open the freezer. Stick their face in the freezer. So these are the kids, like they make sounds like moderate to severe croup, and you get them in the car, and you don't want to turn the heat on because it's going to make it worse. And so in 30 degrees, you drive them to the ER, and they don't sound that bad when they get there, and they're like looking at you like, why'd you bring them in? It's because they were in the cold air. That kind of stuff, yeah. Other diagnoses you should consider when you have a sudden onset of stridor in a well child. Upper airway obstruction from foreign body. They've gotten into something and swallowed it, yeah. So some type of foreign body aspiration or choking. How do you cut a hot dog? You cut it into circles, and then you cut the circles in half. Half moons. Not whole moons. Oh. I bet you feed them popcorn and whole grapes too, huh? I promise you, all these things my children have done, they were watching with their cousins. This is when they were, they're 7 and 9 now, mind you. But they were watching iCarly or something, and they'd been putting blueberries up their nose on the show and shooting them out. And so they get home, and they disappear in somebody's room, and they come out. Don't ask me where they found these. But my daughter had a raisin up one side and a Cheerio up the other, and she was smiling and happy as she could be. And I'm like, you don't stick things up people's nose, and you don't let people stick things up your nose. And they're always fun. My son climbed on a lock cabinet, pushed a chair over, climbed it up, got in a cabinet, opened a childproof bottle of Tylenol, and drank it. So, and when we're there at the hospital, you have to wait 4 hours for the Tylenol level to maximize. Be aware, even if they drink a whole bottle of Tylenol, if they had to drink the whole bottle, that's the toxic amount. All right, so unless they're drinking 3 or 4, they're probably fine. We get home, one of them climbs over the couch and I'm just like, stop. So we're always having fun. So anyway, he was in more distress, I think, and risk of a fracture trying to jump on and off the gurney while we were in the hospital for 4 hours than from drinking the Tylenol. So, real fun. All right. The adventures of pediatric nurses at home. Okay, so epiglottitis. Jessica, a 5-year-old child, presents in the emergency room with a sudden onset of respiratory stridor upon inspiration, so still kind of the croup presentation, and a temp of 1025. So that's where we're talking about that bacterial, the higher fever. My son came home one day, felt bad, didn't have a fever, woke up from a nap an hour later and he had 104 temp. So that's when they start worrying about epiglottitis versus croup. So if they have a really high fever, if they're not sure if it's viral or bacterial, they may go ahead and give them antibiotics. Okay? But for the most part, unless it's bacterial, they're not going to. So most of the time you're going to see just the steroids. But with epiglottitis, a little bit different. All right, so this kid is drooling and prefers to sit forward with her chin slightly protruded, so that whole tripoding position. Her mom states she developed difficulty breathing so suddenly, and both the mom and child appear anxious. So this is a very quick, elevated high fever, issues with breathing, very sudden. So you can see this is an old picture, right? The reason we have this is because we don't see it a lot anymore. So tripoding position, mouth jutted forward, you see that swelling, you see she's drooling because she can't manage her secretions. She's looking like she's decreased OC. So we've got inspiratory stridor, draining in the tripod position. She's a temp of 39.2. And sudden onset of fever and respiratory distress, so that's what we're concerned about. Yep. So when we're talking about epiglottitis and creep, are we talking about upper respiratory or lower? Upper. Okay. Yeah, tell me when to go. So if we're talking about stridor, we're talking about upper airway obstruction. Okay, what actions or what nursing interventions, what are our initial actions going to include? We may want to give them, if they can swallow, we may want to give them an antipyretic. What are we more worried about before we give anything? Do they have an airway? Yeah, are they breathing? Good. So we want to establish and maintain an airway. When we're looking at, we talked about the steeple sign with like LTB and creep, with epiglottitis, if they were to take an x-ray, they'll see what's called the thumb sign. So that means they're looking sideways. They take an x-ray and their epiglottis is so swollen across that it's like this over the airway. Okay? So we want to establish and maintain the airway. That may be by letting them sit in their tripod position right there and be happy. We're sitting in mom's lap. It may be elevating the head of bed. We may have to bag them if we need to, if they're not able to maintain it. We are not going to tell them to lay down. We are not going to send them off the unit for a x-ray. If anything, and they want an x-ray, they need to come to you. You want to leave them where they're comfortable because they are keeping their airway open, and you're going to limit stimulation. We're not going to start an IV. Are we going to go try to obtain a throat culture on this patient to determine if we think that's what's causing it? What's going to happen when they stick something down their throat? Yeah, they're going to lose their airway. So, if you're working in the hospital in July or August and you get a bunch of new residents and they're all gung-ho and they're like, oh, I think it's epiglottitis, let's go swab their throat. You're going to be like, no, you're not touching my patient. Any manipulation of the airway can cause tracheospasm and obstruction. So, no, we're not going to do that. They would rather turn around and give them antibiotics than, try to do that. So, interventions to maintain a patent airway. We already talked about we may have to bag them if we need to. So, if they have an airway, if they're able to maintain it, we're going to try to put oxygen on them. If that's going to be too irritating to them to put a face mask on them, especially with small children, you may have the parent hold it, things like whatever you can do. If they lose consciousness, if they're unable to maintain their airway, we have to bag them until the doctor's ready to intubate. When you see this kid come in, or when you hear about this kid, you want to make sure that you have an intubation set and a trach tray at the bedside. As they go to intubate them, if the airway is smaller, or if it's really swollen, then they have to use a smaller tube. If it is so swollen that they can't intubate them, they may have to trach them, because that's going to be lower than the epiglottis. Once they get that airway established, then they're going to worry about IV hydration and IV antibiotics. If they have to do that, they're going to be in the hospital for about a week with IV antibiotics, and then they're going to send them home with oral antibiotics. So prevention for this is the Hib vaccine, or the Haemophilus influenza type B vaccine. So the Hib vaccine protects against epiglottitis, it protects against some types of pneumonia, some types of meningitis, and things like that. But this is the biggest thing. This is why kids need the Hib vaccine, and this is why you don't see epiglottitis that much anymore, because they're vaccinated. Now, if you have a kid come in with creep-like or upper airway obstruction syndrome type symptoms, and they tell you they're unvaccinated, then you start to worry about epiglottitis more than croup. Okay. The biggest prevention for all of these respiratory illnesses is wash your hands. And I will say, if you have not been around children, you may get sick this semester. I'm going to warn you in advance. Wash your hands, gel in, foam out. You never know who has what and what you're going to pick up. When I went and got my flu shot over Labor Day weekend, I had already been told they'd already had 4 confirmed cases of flu, and that it's very early this year. Both my kiddos got type B last year that wasn't being covered on the flu shot. So we all had fun Tamiflu. It's very expensive. So wash your hands. Make sure you get your flu shot if you haven't gotten it yet. All right, bronchiolitis. Anytime you see anything that says copious, copious means lots and lots running down their face. Copious nasal secretions, think bronchiolitis. Okay. A 3-month-old male infant presents with copious nasal secretions and a fever for the past few days. They come in and the infant's crying in mom's arms. Mom tells you the infant's been unable to eat for the past 12 hours. That's not good, is it? During your nursing assessment, you note subcostal retractions, inspiratory and expiratory wheezing. So if we're hearing wheezing, what part of the airway are we talking about? Lower airways. Okay. Their weight is 5.9 kilos, which is about 13 pounds-ish. Vitals 37.9, heart rate 150, respiratory rate of 52, blood pressure 110/70, O2 sats of 93% on room air. And they have diagnosed this patient with bronchiolitis. All right, so what about this assessment are we concerned about? The O2 sats are 93%, so we're concerned about that. What else? Blood pressure is high for a 3-month-old. Respiratory rate's 52. And when you're looking at newborns, you're thinking 60. So when you're looking at infants, 30 to 60. So if you're at 52, it's on the higher end. Okay, just to kind of help with that. Heart rate's a little high. Slightly elevated temp. What else are we worried about? Mom told you hadn't eaten in 12 hours. You're worried about dehydration because that's going to be their primary source of nutrition is going to be formula or breast milk, and the kid hasn't eaten. So how are we going to know if they're dehydrated or not? Okay, so it's a 3-month-old, so we can check their fontanelles, so we can see if they are, flat. We can see if they're depressed. What else? Look around their eyes. Are they sunken? What else? Wet diapers. So that's going to be our, when we look at kids, and we look at anybody, if they're peeing, which means their kidneys are perfusing. So, Alright, so are they peeing? So have they had wet diapers? And you kind of want to look at their weight. So the biggest thing when you're in the hospital that you're looking at, a food status indicator, is like a daily weight. But yeah, when the kids come in, you're wanting to know how many wet diapers have they had then in the past 12. If they haven't eaten 12 hours, when was their last wet diaper? Was it, really wet? Was it just a little? That kind of stuff. All right. The most likely organism causing bronchiolitis is RSV. You'll see those commercials, fun commercials on TV. Or the respiratory syncytial virus. All these things have really funky names, but the abbreviations are much easier. How are we going to know what's the cause? What are they going to do to find out whether it's RSV or what's causing the bronchiolitis? Sputum culture. So they will either have them hack up something, or they will take that fun little thing and stick it up in their nose and swipe it and get a good booger or snot on it, and they will not be happy with you after that. Now, RSV in itself causes lots of things. It can cause pneumonia. It can cause, creep-like stuff. It can cause bronchiolitis. Okay, we can get RSV and walk around and think we have a cold. Okay, so just remember, adults, bigger airways, we don't have the same issues that they do. Okay, so we're talking about a lower respiratory problem. You're seeing the wheezing and subcostal retractions that help reinforce that. Other signs you might expect this patient to exhibit. So you may see some nasal flaring. especially with those copious nasal secretions, you may start to see cool extremities. Because when we're worried about dehydration, we start to worry about hypovolemia and hypovolemic shock. So you're going to see cool extremities, you're going to see poor peripheral pulses. If that is the case, is that going to make that O2 saturation the most accurate? No, as far as when we're looking at oxygenation. Okay. So we're not perfusing oxygenated blood is basically the deal. So cool extremities, poor peripheral pulses, they may be pale, they may be sleepy, and you may see decreased urine output. Nursing interventions appropriate for this patient. RSV is a virus. Are we going to give this patient antibiotics? Nope. We have to kind of wait. We're going to wait for it to pass. So what are we going to do? It's all supportive care. Suction, oxygen, rehydration. So you're going to suction the oral and nasopharynx. The biggest thing with suctioning is bulb suction. You are going to bulb suction. You're going to teach the parent how to bulb suction correctly. You're going to make sure that they return, demonstrate, and show you they know how to do it. Oxygen via nasal cannula and face mask, be aware. Like we talked about, copious nasal secretions. If your kid has on oxygen and they start to have further distress and desat, the first thing you're going to do is suction their nose and see if that helps. They're going to be on contact droplet isolation. We don't want to share this. You're not going to put them with some other high-risk patient. We already talked about the sputum culture. Oral rehydration versus IV fluid. You're going to talk about that more when you talk about GI and gastroenteritis and things like that. But primarily, the first thing we always do if the patient can drink, because it's least invasive to mild to moderate dehydration, you're going to rehydrate them orally with clear fluids, Pedialyte, that kind of stuff. Alright, so we go back and reassess our kiddo and his temp is now 39. What are we going to do? Take sclerosis off. What else? We can give him a cool bath. Can we give him an antipyretic? What kind are we going to give him? He's 3 months old. Can we give ibuprofen to a 3-month-old? Yep, 6 months and older. Tylenol. Alright. So, I'm not going to make a calculate this. We'll just move on. So, what's an appropriate dose of acetaminophen for his weight of 5.9 kilos? Remember, Yes, just get it in your head that 10 to 15 is Tylenol. Alright, so discharge teaching with this kiddo. How to suction, bulb suction, give them a piece of paper, because when parents come in, you think a 3-month-old, if that's their first child, if they're very nervous, if it's the first time the kid's been sick, when you start to tell them all these things, are they going to remember and understand? No. So you always want to give them written instructions in their language. You always want to give them a demo. You always want them to return, demonstrate that they know what to do. Other things that you need to give them written. Doses of Tylenol. How much they need to draw up, be it in mils or be it in teaspoons, that kind of conversion stuff. If they go to the pharmacy and you tell them they're supposed to give 1 teaspoon and they give them a syringe that has mils on it, this is the most common cause of type of med errors with children is when they're sent home with inappropriate or not complete discharge instructions on how to administer medications. Okay. I don't know why they did that, but anyway, so bulb suction demonstration. Signs of respiratory distress. What to watch for at home. This kid can have a cough and nasal discharge for weeks. But they need to know when to come back to the doctor or the hospital. They need to know to wash their hands if they have other small children at home. They need to know how to keep them, safe as well. They need to make sure that they keep up to date on immunizations. We talked about pushing fluids. So who's at the greatest risk for severe illness with respiratory syncytial virus or RSV? Kids with underlying respiratory conditions, if they are premature or born earlier than 35 weeks, if they have some type of underlying congenital heart or respiratory disorder, like we talked about kind of asthma stuff, they really don't diagnose asthma until about age 5, but other types of just chronic respiratory disorders like cystic fibrosis and things like that. One of the things they can do for these kiddos is they can give them an immunization for prevention. It's called Synagis, and it's on y'all's other set of notes, but it's very expensive, and they have to have a shot every month during RSV season. So it can generally be 4 to 5 shots per season. The shots are very expensive, about $1,000 a pop. Sometimes insurance covers it, sometimes it doesn't. I think it's better, a little bit better now than it was. If they are still less than, I want to say 18 months, 2 years old, by the time the second RSV season rolls around, then they have to have it for 2 RSV seasons. Okay? And that's what can help prevent that. It's only for, they only consider it for high risk. They won't just do it for a normal newborn. Yes. Yes, they would get it too. Like if you've got kids in the newborn nursery or something like that, yes. Or I mean the NICU, yes. But like we said, it's expensive. It's all that kind of fun stuff, like that. The big deal is when you look at patient assignments and things like that, you're not going to assign a nurse somebody that has a kid with RSV and then also has another newborn or neonate. You're not going to float a NICU nurse to peds and give her the RSV kid because then she's going to go back to NICU. That kind of stuff. So that's what we're worried about. We don't want to spread it because they're already at high risk. Okay. All right. Asthma. So when we talk about 80% of hospitalizations are respiratory, the biggest portion of those and biggest cause of missed school days is related to asthma and asthma exacerbations. So when you look at asthma, it's the excessive reaction of normal protective mechanisms. So, our bodies normally, you're cleaning the house, you stir up dust, you normally start, snotting and coughing and things like that because it's trying to get that stuff out of your airway. But what you have with asthma is you have a hyperreactive thing going on. So you have bronchospasm, you have mucosal edema, and you have this increased mucus formation. Okay, so your bronchial tubes start spasming, they get swollen and edematous, and then you start to have increased mucus formation, which is just going to plug up and block that airway. So with asthma, as it being a chronic condition, you have persistent symptoms, or chronic symptoms, and then you have acute exacerbations. So depending on, with any type of chronic respiratory disorder, it depends on how well, obviously, some people have worse asthma or worse cystic fibrosis than others, just genetically and things like that. But it also depends on how well it's managed. Okay? So, and how adherent they are with the treatment program. If they're non-compliant, they're probably going to have more issues. Okay? So with this chronic inflammation over time, you do get airway remodeling. So the mucosa of the airway gets thickened as it is, so it's more prone to obstruction when it does swell. You start to get that smooth muscle hypertrophy. It's hyperactive. So when they're exposed to triggers, they react worse. And then you start to get this constant chronic overproduction of mucus. Okay? So your airway is already hypersensitive, and so we always want to try to control our symptoms to prevent exacerbation. So if you know what the triggers are, they want to avoid them. And so what an acute exacerbation is what a lot of people think of as an asthma attack. And what they look at with that is, they may have a cough, and as we talk about the different variations and types of asthma, we'll cover that in a little bit. They have wheezing, shortness of breath, increased respiratory rate, nasal flowing. Are we seeing a pattern here? Retractions. With this is where you're going to see the tightening down of those bronchioles and the bronchial tubes, and so then they have decreased or no air movement when you go listen to them, and so that can make them hypoxic. All right. We're going to talk about Danielle. So she's 6, and they come into the community health clinic with mom. The child presents with a history of wheezing, shortness of breath, chest tightness, and a cough that developed last night. The child's lethargic and pale, and her skin is cool and clammy, so she's diaphoretic. She's sitting in a tripod position, and her eyes are open wide with a fearful countenance. So she sounds like she's having a little bit of distress, right? So when we're trying to determine if it's an asthma exacerbation or not, what kind of historical data do we want to know to help clarify what's going on? Huh? Right, do they have a history of asthma? If it's the first time, do they have a family history of asthma? How many times have they come in with respiratory, illnesses? Have they been exposed to anything new, like animals, environmental factors, chemicals, home or school? Number of occurrences. So as we talk about, a lot of kids have respiratory type illnesses. They may get croup, they may have some wheezing, they may have some upper and lower airway issues due to viral and things like that. So they don't usually diagnose a lot of these things until 4 or 5, depending on how severe they are. They start watching and see how long they come in and see if they you don't outgrow asthma, okay? You always have it. However, you may get, as you get older and bigger, if you have mild asthma and your airways get bigger, you may not react as bad, if that makes sense. So we're talking about upper or lower respiratory? Lower. Okay. We've got wheezing, we've got chest tightness. Talking about the lower airway. Yes?
Since it's a histamine response, like an APs or something like that, like as you get, like I said, that allergies, that anymore. And then when I lived in Arizona, it wasn't near as bad as it is here.
Some of that just depends on the different types of pollen and the different types of things in the air, because some people have seasonal types of allergies, and it depends on, do we have worse this type of year? Are we having different types of cool and warm fronts that are blowing it down from different places? Yes, depending on what they're triggered by. Yes. So pretty much the kid went on a Boy Scout camping trip or something like that, got out in the woods, they may come back with an asthma exacerbation. When we had that cool front kind of coming in every day with rain, that's when you're going to see a bunch of asthmatics in the ER or in the doctor's office the next night or morning. Okay? Anytime we have like a seasonal type change. Is this child in respiratory distress? Yes. Okay, we've got signs and symptoms are showing nasal flaring, retractions, poor chest expansion. We see those cool extremities. So as you see, when we're looking at this whole oxygenation, we're also talking about perfusion as well. Okay, so y'all will talk about that when you talk about cardiac and talk about shock. That seems to be something that's hard when people look at, is looking at shock and perfusion, and we're looking at the whole picture. So you're not just looking at O2 sats, but you're looking at the pulses and the quality and where you're finding them. You're looking at their color. So you're looking at color, cap refill, pulses, if they have edema or not, their temperature overall, skin temp, things like that. Alright, so initial intervention with this patient. So we're going to go ahead and give them 100% oxygen via face mask. We're going to leave them sitting up. We're going to raise the head of the bed if the bed's down, and whatever position they're comfortable in, we're going to let them be in. What kind of medications are we going to give? Albuterol, most likely, for a bronchodilator. If albuterol is not necessarily effective, or if they have problems, sometimes they'll use Openex or Love albuterol. So they need a fast-acting bronchodilator. Okay, so that would generally be albuterol. How are we going to know if the oxygen and the bronchodilators are effective? So hopefully the wheezing will decrease. Hopefully we can hear more air movement throughout the chest. What else? They don't look as distressed. Okay, maybe they can talk to you in a complete sentence versus, a few short words. They can tell you that their chest feels better and doesn't feel tight. Hopefully, like you said, they look better. They're more alert. They might be pinker. So. Y'all tell me when y'all are ready. Okay. All right. Oh. Somebody start writing. Now we're going to go back to those notes and talk about asthma meds. Okay. So different types of asthma medications. So we give rescuers and controllers. Our rescue meds are generally going to be our beta-2 agonist or short-acting beta-2 agonist, which is going to be your bronchodilators. So that's going to be your albuterol, your levalbuterol. They may use terbutaline. That's generally only if it's severe and it can't be controlled by the other. They're going to use steroids, corticosteroids. So things like methylprednisolone, which is solumedrol, prednisolone, Orapred, dexamethasone, things like that. And then they use anticholinergics like ipratropium bromide. Occasionally what you will see is like the anticholinergic and the short-acting beta-2 agonist in one. They'll pour them both in the nebulizer and give it to them. If we are having to give multiple medications, we always want to give the bronchodilator first before we give the corticosteroid. Why is that? So it opens up the airway more so the corticosteroid can get down and further and work better. Okay. What side effects are we going to see when we give albuterol? You're going to see an increased heart rate. You're going to see them get jittery, then maybe a little anxious. That's a normal side effect. Their heart rate's going to shoot up. Are we going to do anything about that? No, we're going to watch them. It's a side effect. Okay. Levalbuterol is more expensive. Okay. When you're looking at medications and things like that. However, if they get over jittery, if there's a really problem and their heart rate goes out of control when you give albuterol, the levalbuterol will still do that, but not as bad. So they may use that, but most of the time you're going to see albuterol. Alright, so with controllers, that's where you're going to see your long-acting beta-2 agonists. So these are going to be kids that have moderate to severe persistent asthma. They're the ones you're going to see with these controllers and multiple medications. So you may see some type of combination of these things. So when you're looking at Advair, for example, that's actually a long-acting beta-2 agonist and a corticosteroid mixed in one. Okay, it's salmeterol and the fluticasone. You may see them take Singulair and things like that. So just to be aware, they may have, the more severe the asthma is, the more medications you're going to see them on. Okay. If they have a controller medication, when do they take it? Every day, not just when they're feeling bad. They need to take it every day. What's the big side effect we're looking at with corticosteroids? Huh? Orally, what's the big side effect we're worried about? Worried about thrush. So anytime they take an oral corticosteroid, you want them to make sure they're rinsing their mouth out afterwards. With steroids in kids, because long-term corticosteroid use can cause growth retardation, we try not to use steroids with children unless we have to. However, with respiratory, you will see it used because we need to breathe, right? Other things with long-term corticosteroid use, you'll start to see that moon phase. We don't do anything about it. We just know that it's a side effect of long. So if you see a kid with that, that means they've been on it a while. They probably have poor control and severe asthma when you're assessing them. So yeah, it's just a picture of some of the different types of inhalers you'll see. So on the right, you'll see a propellant inhaler, and on the left, that's a dry powder inhaler. That's the Advair. With the propellant inhalers, you always want to use them with a spacer. People don't like to because they have to carry it around and it's bulky and things like that. However, it's more effective if you just spray it in your mouth. You're getting most of it in the back of your throat versus if you're using an inhaler. the medication's going into the chamber and you're able to breathe in and out, you're actually inhaling more of the medication. The nice thing with kids, small kids that it's like, walking and talking and chewing gum and things like that, if they're not able to control it with the mouthpiece with the spacer, you have the mask. So it doesn't matter if they're crying, if they don't like it or anything else, it's a soft mask. You just push it up against their face and you push the thing, and as they breathe in and out and cry, they breathe in the medication. So when we're giving nebulizers and things like that, we don't care if they're upset because it just makes them breathe in more of the medication. All right. With a little bit older kids, like 5 and up, sometimes it gives them more control to feel like that they're putting the mouthpiece in their mouth or that they're holding the nebulizer pipe versus the mask. So it's something you can give them a choice with. With our nebulizers and our aerosolized medication, this is just a picture of we're pouring this in the chamber. A quick trick if you're challenged with using multiple hands at one time, you can actually just pour it with the thing screwed in the top of that little tube. Keeps you from trying to dump it out. But here's a picture of the nebulizer with the mask. It also has the pipe, and then this is a picture of the nebulizer mixed into a bag valve mask or an oxygen mask. If you're having to hold it on their face, you can mainline it into that as well. So you're either going to use it with compressed or nebulized air, just the nebulizer on itself, or it may be running through with oxygen pressure on the wall. This is a picture of a kid having it with the mask and the spacer. So when we take this, they should take, like say most of the time you're going to get 1 or 2 puffs. If they have more than 1 puff, they really should be spaced about 2 minutes apart to allow the first one to take the most effect and then get the second one in. You're going to need to shake it. So you're going to shake it for 5 seconds. They're going to do their puff. They're going to breathe in for 10. If it's in the chamber, they can breathe in and out in the chamber. Okay? So if you're not using a spacer and you're just putting it in your mouth, they need to hold the breath. Okay? Alright, so with asthma, this is something y'all do need to know. It's along a continuum of severity, and what they do with that is they look at how their symptoms with everything. You want to look at how it affects their daily life and their ADLs. So with kids, how does it affect their play, their sleep, their schoolwork, things like that. So mild intermittent asthma, they have symptoms less than 2 times a week. Okay, the types of symptoms they're looking at, like nighttime cough, not being able to sleep at night due to respiratory distress, interference with normal activity, that kind of stuff. So no interference with normal activity. These kids are generally going to have just a PRN rescue medication and no controller. So they're going to have like their albuterol inhaler. Maybe they only have exercise-induced asthma. So that means they're just going to have their inhaler, and to help prevent that, we're going to use their inhaler as a preventative before they have an attack, like say prior to their soccer game, that kind of stuff. Okay. Versus mild persistent asthma, it's more than 2 times a week. The nighttime symptoms, they're woken up with a nighttime cough or wake up with a morning cough more than 2 times a month, and it's causing some limitations. So they will have a PRN rescue med, and then they'll have like a corticosteroid controller. As you get in, you start to see moderate persistent, affects them every day. Nighttime symptoms are more frequent. It does limit some daily activities, and they're going to start to have a long-acting bronchodilator in addition to the other. Versus severe persistent, you see it's very poorly controlled, and they're actually going to have oral corticosteroids as well. And that's what we try to avoid, is giving them systemic oral corticosteroids. Okay. So they look at this based on whether they're less than or greater than 5 years of age, how often they have exacerbations, the types of symptoms they have, and all of that's going to guide that regimen. So they're going to review this plan depending on how many exacerbations they have, more frequently versus less, but about every 1 to 6 months, and the goal is like symptom control. You want to reduce the frequency of exacerbations. So this is going to guide as we talk about their asthma action plan and things like that. So they're going to have it on file at home, they're going to have it on file at school, and those types of things. So the biggest things with nursing care that we're concerned about is a good, solid first assessment of your patient. You always want to reassess and see what's going on. Humidified oxygen nebulizers as needed, other comfort measures, maintaining that airway, hydration, and then decreasing stress. Because of asthma, being a chronic illness, it's very important. There's a lot of teaching that goes on with it. Newly diagnosed patients, they actually have classes at the hospital they have to go to before discharge, things like that. So they need to know about the disease process. They need to know what happens and why. Medications, so the schedule for administration, the order, that kind of stuff, how they give them, how to do a nebulizer, how to do an inhaler, when to use a spacer, that kind of stuff. For some states you have to have a prescription to get a spacer. Some you don't. It's prescription for nebulizer, tubing, things like that. What kind of stuff if they have to have home equipment and medications. Peak expiratory flow readings and how to do those, and we'll talk about those next. The asthma action plan, what it is, how to read it, what to do. It's going to guide them. The biggest thing with lifestyle modifications is trigger control, and depending on what their triggers are, it may be a bigger change than others, and then the biggest goal is prevention. So peak expiratory flow readings. So basically this is going to measure their ability to push air forcefully out of the lungs, so how forcefully they can breathe out. And this is just kind of how you're going to tell them to do it. So they always need to stand up straight when doing this, or sit up straight when they're doing any kind of pulmonary function test. If they're sitting down in a chair that's crushing, you're not going to get the most accurate thing. This is a picture of one type of peak flow meter. Make sure the meter's set to 0. They're going to take a deep breath. This is going to be done when they're feeling good to get the baseline, okay? When they're not having a bunch of symptoms. You're going to tell them they're going to blow out hard and fast. So, as long and as hard and as fast as they can. So you can either tell them like you're blowing like a dragon breathing fire, like you're blowing out the candles on a birthday cake, that kind of stuff. And you're going to record the highest number of 3 tries. And that's going to be considered their personal best and their baseline. Okay? So then when they come to the hospital and have an issue, and they feel sick, they're going to have them do their peak flow again, and they're going to see where that falls. Okay? If we went in and we weren't diagnosed with asthma, but they wanted to check our peak flow and things like that, there are all kinds of fun charts that talk about height and weight and age and things like that gives them the peak flow that you should have as well. So at home, they should be doing this then every day, and they start to look at, what days they feel worse, and it helps them figure out what's going on. So with their asthma action plan, it's based on their peak expiratory flow readings. So their green zone is considered 80 to 100% of personal best. All right. They have no symptoms, and they're going to take their usual medications. Wherever they fall on that continuum from mild intermittent to severe persistent asthma, they're going to take whatever they normally take. Okay. The yellow zone is 50 to 80% of that personal best, and that's going to mean that they do have some symptoms and they need to take that short-acting beta-2 agonist and, call the doctor. Okay? I like this one. It's very, one of the ones that I've seen that's really colorful, and it kind of gives them ideas of, what symptoms they're experiencing as well as triggers. Yeah. The red zone is less than 50%. That means they need to take their short-acting inhaler and go call the doctor and go in and see somebody or go to the ER. Okay? And it's going to tell them what they need to take and when. Questions on that? And this is generally going to be on file with the physician. They're going to have one that's going to be on file with the school. Types of triggers. Pets. Anything pet dander. We have some with exercise-induced asthma. We talked about pollen, bugs in the home, Cockroach excrement. Very big trigger and cause of issues with patients with asthma. We had some kiddos come in with muscular dystrophy one time. We were doing coordination of care for it, Scottish Rite, and their Bi-pap machines had cockroaches in them. So can you imagine what they were breathing in? And they stayed for several weeks, and you'd have to walk into the room and hit the light, and you'd hear. It was lovely. They actually had to go out and bomb their home. It was that bad. Never fun. So I just always think about that because you think what they were breathing in. Okay. Chemical fumes. So any type, certain people react to certain hairspray, just different types of things. Perfumes. This is why we talk about not wearing strong scents in the hospital and things like that, because it can bother patients with asthma or respiratory problems. Cold air, hot air. So different types of seasonal changes. Fungal spores with the pollen. None of us have time to clean, so we all have dust, right? Smoking, other strong odors, pollution. So when I lived in Galveston, and you have all the things in Houston and all of that, I had worse allergies there than I have here. Yeah. So it's stress. So if they're stressing about a test or certain times of the year, they can have an asthma exacerbation. Okay. Things that we can do with this. Avoid exposure to tobacco smoke. We talked about this a little bit earlier. A lot of times they'll tell them, if you have somebody in the house, wear a different shirt outside and take it off as you come in if you're going to smoke. Just anything that can help reduce that if you're around, kids with asthma and respiratory problems. Reduce indoor humidity. So they may need a dehumidifier. You do want some humidity. You don't want it too dry, but you want it less than 50%. Okay. Yeah.
I've noticed some of the slides that things like cool or warm to get
humidified air. Just pretty much humidified air. You don't want it ice cold. But the deal with kids, a lot of the times we don't use heated humidifiers, and the reason for that is burns. It's safety. It's a safety issue. That's the biggest deal. The biggest reason you want to use heated was with high flow oxygen. But as far as if you're talking about sticking their head in the freezer for croup, that's going to be cool versus if you've got the shower going, anything, you're just talking about humidification and moist air. So it really doesn't matter. But burns is the biggest thing with the hot water humidifiers. And you really need to clean those. Those are hard. If they've set since last year, they really need to be cleaned. All right, so the other thing, wash sheets, pillowcases, and comforters every 1 to 2 weeks in hot water. They tell you it needs to be washed in hotter than 120. However, what is the safety setting at home? Less than 120. So, yeah. Vacuum carpets daily. Remove the carpet. So the biggest deal a lot of times with that is they may need to remove the carpet from the bedroom, or they may need and replace it with some type of tile or flooring. Okay, just to help with that. So if they can't remove it from the house, remove it from the bedroom. Same thing with like stuffed animals and things like that. Like my daughter has this menagerie in her bed, and so you would want to get that stuff out of the bed. You would want to try to keep their pets. If you have family pets, you may need to keep them out of their bedroom and off the furniture that they're on all the time. That kind of stuff. When mold and pollen counts and pollution levels are high, orange and red alert days and all of that, you want to keep them indoors. And then exercise induced asthma. That's the biggest thing where you would use the rescue medication prior to the activity, because we're trying to prevent it from happening. Okay. When I finish asthma, and then if y'all need a quick break, we can do that. Come on.
I just don't know what's going on. I recently tried out for cheerleading and couldn't believe it when it was. I was so excited. The problem is, I get out of breath. Sometimes I start coughing. It's really embarrassing and a little scary. We're practicing outside a lot, and I feel like I can't keep up. I've done gymnastics since I was 4 or 5, and never had a problem like this. Now that fall is when the weather's getting colder, I tend to be getting worse. I don't even know if I'll feel well enough to train the next game. My friends would be so upset with me. Oh yeah, as if this isn't bad. I'm not sleeping through the night anymore.
Sounds typical,
I
right?
drink coffee, and I feel like I snore. How gross is that?
That's like when you're asking teenage girls for intake and output, and you're like, when's the last time you pooped? And they look at you like, I don't do that. Yeah, that kind of stuff. Like, I don't know what you're talking about. I don't do that. Yeah. Alright, so this is just talking about allergen sensitivity and things like that, and it's worse with asthma, but basically we're talking about the histamine reaction. So they inhale whatever the allergen is, it gets in their airway, you get that hypersensitivity. With asthma, it's already worse because they're already sensitive. It's IgE mediated, and it's a histamine response. So, status asthmaticus. So anything where you have like that whole status, it's severe, basically severe respiratory distress despite supportive intervention. So we've put them on a continuous albuterol med. It's not helping. We may have to intubate them. We may have to, anytime that they're having to have more than like 40% oxygen, 40-50%, they need to go. They don't need to be on the floor. They need to be monitored more closely than that. So this is severe despite your intervention. So we've got them on oxygen. We've got the head of that elevated. We've been giving them albuterol. They're still progressing, progressively worsening. So because this can progress quickly to respiratory failure and death, they need to be admitted to the ICU. They may go ahead and intubate them and manage as respiratory failure. I mean, I've seen kids with RSV end up on ECMO. So, I mean, some of these respiratory things with the smaller kids and little airways can be really severe. All right. So we're talking a little bit about ways when we talk about kids and compliance and developmentally things we can do. So everything we look at with kids, we approach from a developmental perspective. Okay. So Chris is 7 and was recently diagnosed with mild asthma. He wants to play on the school soccer team, but his mom states she's afraid all that running will cause him to have an asthma attack. How do we need to respond to that? So you've talked about it. They can use the rescue inhaler before. When we're looking at kids like that, are we going to say, no, keep them in the house, don't play? No, we need them to exercise. We need them to run and play. We obviously, with all the problems with obesity and everything in the United States, if they're engaged in something and active and like it, we want to encourage it. Okay, so we need to address that fear, straight on, and they can prevent that with using a short-acting bronchodilator beforehand. Okay. So Diana's 5, and she has severe persistent asthma. Okay, so she has frequent exacerbations. She frequently has to have nebulizer treatments at home and school. She is non-compliant with the treatments and continually pulls the nebulizer mask off of her face and screams she doesn't like the stupid mask. What can we do about that? They do have the animal mask. They actually have one that's attached to a pacifier, too. It's got a pacifier and got a little nose piece. It's kind of cool, but anyway. They have funny-looking nebulizers that look like teddy bears, and we have one that looks like a duck at home, things like that. So, yeah, you can try to find a mask or something she likes. What else? Yep. Can we bribe? We bribe children. We unashamedly, we do not. Right, is there something she likes to color? If she's at school, can she color while she's doing it in the nurse's office? Can she watch a favorite TV show at home while she's doing it? Is there something she can hold, and look at? Anything like that. When you're talking about in the hospital setting, can you give them a reward chart or a sticker chart or a prize box or, things like that. It's called positive reinforcement, not bribery. It sounds so much better. But now, is a 5-year-old going to understand that? No. I say, look, it's your fault. You had the thing in your face. You just made me do that. Yeah, no. Didn't work. Alright. Jeff is 16 with moderate persistent asthma. He presents to the ER in respiratory distress following a school field trip to the nature museum and park. Yeah, they went out to a herd museum and had a lot of fun. Upon further questioning, Jeff reveals that he hasn't been taking his controlling meds and refused to use the rescue inhaler in front of his friends. Why is that? Because he's 16, and it's this whole body image and perception and peers, and he's going to look different. And, you know, we all want to be individuals, but we want to dress the same, you know, that kind of thing. All right. So he doesn't want to look different than his friends. Same reason diabetics don't want to check their blood sugar or use their medication, you know, any of these types of things. So what are we going to do about this? So either you can try to, you know, involve friends. What else can you do? He's 16. In 2 years, he's going to age out of pediatric care for most things, unless it's a chronic condition that you don't see a lot in peds, at which he'll age out about 21. Can he start calling and managing and being more responsible and handling some of his things? So maybe, you know, some of it could be a control issue. You can help try to figure out how to do it away from his friends. You can try to involve some of his friends, but you can also, a lot of the times with older kids, they do really well with care contracts. Because they're actually having to, you know, sign something and contract that they're going to do that. Now that's the one you can say, yeah, have an attack and see. They're going to say, that couldn't happen to me. That's not my fault. All right, do I need a quick break? All right. Come back at, I guess, 25 after. All right, cystic fibrosis. This is a really neat population of patients to work with. It really is. All right. CF is an autosomal recessive exocrine gland dysfunction. What does that mean? Huh? Both parents have to have the gene to pass it on. So it's not it's dad's fault, it's mom's family's fault, they have it. You know, it's a blame everybody or blame no one kind of thing. So they both have to have it, and then this is just a nice visual of what that means. So if mom and dad, both their carriers, and there's a 25% chance with each pregnancy. Not if they have 4 children, this will be the thing, but with each pregnancy, there is a 25% chance that they will have one child that their child will not be a carrier. There's a 50% chance that the child will be a carrier, and a 25% chance that the child will be affected with each pregnancy. So autosomal recessive, both parents have the gene. Exocrine gland, so that's talking about we're excreting, so that's going to be like your sweat glands, your mucus glands, that kind of stuff. Okay. So you're going to have increased viscosity of mucus gland secretion, so thick, sticky mucus. All right, and it's going to be down in their lungs, and it's going to sit there and be thick. So what do you think is going to happen anytime anything sits? Bacteria likes to grow, yes. They have high sweat electrolytes, so they excrete this through their sweat. So what they're losing, they lose a lot of sodium through their sweat. So they'll have salty skin, and they're at risk for heat exhaustion and things like that. Pancreatic insufficiency. Because of all of the mucus, it causes a lot of scarring. So over time, these patients can end up with CF-related diabetes, secondary to that. It's unstoppable. There is no cure. Pulmonary treatments and medicines are help them to live productive, pain-free, lives. Generally about 30 is about the survival for that, the age, life expectancy. Okay. So this is our little man. He's on your sheet, your case studies. And the good thing about CF affects the whole body, pretty much every system when you look at it. So, starting with respiratory, which is up here kind of in the blue on the left, on your right, sorry. Like I said, they have thick, sticky mucus. What that means is they're at a risk for infection. These kids, they get MRSA in their sputum. They get Pseudomonas. I've seen some with Aspergillus. So some pretty funky stuff. So some of them are on antibiotics prophylactically to help prevent that, or to help prevent reinfection. The biggest deal about this is all CFOs carry all kinds of funny organisms. If you put them all in the same room, they're going to share them because they're coughing and things like that. So really, you should not have a CF patient within 3 feet of another one. And they need to have a mask on. Okay. So when you have all these other chronic disorders, this is the problem with that, is that they have all these support groups and things for the kids to go to, and cystic fibrosis camps and things like that, or, other camps for spina bifida and things like that. We don't have CF camps because they would all share all their fun germs. So, that's the biggest thing with that. So they'll have them on antibiotics. They will also bring them into the hospital frequently for what they call pulmonary toileting or pulmonary tune-ups, where they will give them antibiotics and nebs and things like that. Okay, so because of that thick mucus, we have to break it up, and they do that with CPT or chest physiotherapy. With the babies, they may use just their hand and pop, or they may have the little handheld manual CPT thing. Looks like you're whacking the baby. With the older kids, they may have the CPT, the vibrators that go through and do that they put on their body, and it vibrates that and breaks that mucus up. They also have the vibrating vests. The nice thing about the vibrating vest, it kind of compresses and it breaks it all up at one time. So a lot of times they'll have the vests. They will be on multiple nebulizers. Things like albuterol to open up their airway. They will be on corticosteroids to help with inflammation. They will also be on nebulized antibiotics and things like that to go down in their lungs. All right. A lot of times they will give those at the same time as they're doing the CPT. Long term with these kids, they start cystic fibrosis is a COPD, or chronic obstructive pulmonary disease. So depending on the severity, you will see them. They may be barrel-chested, like an adult that you've seen with emphysema or something like that. Because it's a COPD, you will have that impaired oxygenation. So over time, depending on the severity, you will see clubbing of their fingers and their toes, their toenails too. And so these kids will be on oxygen. Being that it is COPD, you're not expecting them to be at 100%. You're not going to over-oxygenate them, but a lot of times they're normal, and they may sit normally at 93 or 94. These kids, because it's chronic, and with anything chronic, you have all kinds of control issues. They do not like to wear their masks, and they do not like to wear their oxygen, and things like that. So you have to work with them on that. As far as the GI tract, that mucus, we talked about it, it starts to build up and scar their pancreas. It blocks pancreatic enzymes. So what that means is they're not able to absorb the fat like they need to, certain vitamins from foods. And so if they do not take pancreatic enzymes, they have these really fatty, frothy, bulky stools. And so because of that, with all their meals and snacks, unless, they're eating pizza, if they're eating anything like that, unless it's something else, they have to take pancreolipase with it, which is one type of pancreatic enzyme. We had a kid that was real cute with that one time. She tried to pour it on her hamburger, and so she opened the capsule, and the little things inside are going, pee, 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 and the student's like, no! Yeah, it was really fun. We had one try to hide his under his leg and refuse to take it, and the student's like, you have to take it, and he's like, I'm not going to take it, and it's always fun. So over time, they can also get that fibrous scar tissue and do CF diabetes. Yeah, these kids are very knowledgeable about their disorders. They know what their meds are. They can tell you how they get all their stuff. So they're really neat to talk to. And, really smart kids. You've got the intestinal malabsorption. So with that, this is why these kids are smaller in stature than other children their age. They really need to take in about 150 to 200% of what the normal caloric intake is. So 1.5 to 2 times the normal caloric intake for a child that age is what they need. The problem is, you know how you feel when you have a cold and you're all junky and you don't feel good. You don't want to eat, do you? Do you think they want to eat when they're coughing and gagging and hacking and all of this? No. Never give them breakfast before you do their CPT and treatment. They will throw it up. But because of that, a lot of times these are the kids that they will have a G button or a peg tube. And they will get, Pediasure or some other type of in-all feeds to help with that. They will need, because they don't absorb fat-soluble vitamins, which are the vitamins A, D, E, and K, they will need supplementation with that. They may also have salt supplements as well. So yeah, these kids will be smaller than other kids their size. Okay. Reproductive problems. So a lot of males are sterile due to the mucus in the vas deferens. Females, you have a lot of mucus and things like that, and so it depends, but they may not be able to get, pregnant. With when we talk about the increased loss of fluid and electrolytes in their sweat, so they lose a lot of sodium chloride. They will have salty skin, so sometimes with babies, you'll have them say, "Oh, I tasted my baby and they felt salty," or something like that. Or kissed your baby and they felt salty. We're not tasting babies here, sorry. I don't advise eating babies. They'll be like, "I kissed my baby and they tasted salty." And so one of the things they do to diagnose, consider the gold standard to diagnose CF is the sweat test, but they really can't do it till the baby's like 2 to 4 weeks of age. So if they don't know, they have it, in advance. So they're at a risk for dehydration and fluid electrolyte imbalance. A lot of times they'll have salt supplements. So these are the kids you don't want to overhydrate them with water, okay? Because they can then become hyponatremic. And what happens if we're hyponatremic? It's a bad thing. You can start to get changes in level of consciousness, you can get GI disturbance, you can have seizures, you can have a coma, you can have death, because what happens is all the fluid goes, you get cerebral edema, okay, when you start to have that shift. Other things with these kids, let's see. The earliest sign is a meconium ileus, like if they don't pass a meconium at birth. It's not that. The most common is like rectal prolapse. Most of these kids get diagnosed by, 2 to 4 years of age. If they haven't really diagnosed in utero or at birth, then they look at how many times they've come in with respiratory illness. Or if you have a kid come in with failure to thrive, failure to thrive is a pretty kind of generic, term. I may have talked about that a little bit maybe. But these kids are going to be the ones that they just don't look right. They're not growing, they're not interacting, they're not that kind of things. They work them up for malabsorption disorders like CF with that component, celiac. If they come in and they're underweight, they look at cardiac disorders. So this is one of the things they look at with that. I think the oldest kid I've ever heard of diagnosed with CF was an 8-year-old. She actually came to the hospital with rectal prolapse. And she had some respiratory infections over the years, but it wasn't severe enough that they really did a lot. We used to have a little boy who had CF come in and do this lecture on the CF part. It was kind of fun. But he would tell you about all his meds and everything else. But they have to take multiple meds in the morning and afternoon. They have to work them around school. So it's really hard, with that kind of stuff. She would talk about, they were from Honduras, so she would talk about how every time they went out of the country, they had to haul all of that equipment and get it approved and all the medications. So, yeah, from the stools. So a lot of times with the pancreatic enzymes, what they will, they adjust them based on what the stools look like and that kind of stuff. So if they may need to increase them. If they're having more frequent stools, they may need to, if they're fine, they may decrease them, but they always need to take them. Okay. All right. So when we're talking about infants and trust versus mistrust and developmental issues, Mason's a 6-month-old with CF. He's come to the hospital for the first time. While completing the admission questions, his mom tells you that even though he loves eating baby food, he's not been gaining weight. She's also noticed that his stools have been greasy with a stronger odor than usual. What do you think's the cause of this? Because with babies, we're not giving them pancreatic enzyme pills. They actually have a special formula that has the pancreatic enzymes in them. Okay, so either he's not getting enough of the enzymes, they may need to change what's going on, or things like that. Okay, and that's why he's not gaining weight, because he's not absorbing the nutrients he needs. He may also need extra supplementation with some type of enteral feeds, either a nasogastric tube or a PEG tube. Alright, so for toddlers, Sophia is a 3-year-old CF patient. While hospitalized, she noticed that her parents don't discipline her bad behavior. It's one of those fun things. You'll probably talk a little about this when y'all talked about communication. They're also not very helpful when she refuses to take her enzymes with meals. What do you think is the cause for this, and what long-term effects can this have? Guilt. They feel guilty. It's their fault the kid has CF. She's got a chronic disorder. They know she's not going to, live that long. So they're going to let her do whatever she wants. Well, with kids with chronic disorders, especially with CF, they've got a lot of medical treatments. So it's only going to get worse if they don't manage to discipline or to motivate her with positive reinforcement or sticker charts or, something to work with her. Over time, she's going to have more lung scarring. She's going to, with the non-compliant, she's going to have more issues. She may have to have a lung transplant. She may not live as long, that kind of stuff over time. Yeah. That and failure. Yeah. Yeah, usually infection or scarring just for failure. Yeah, usually infection. They can have lung transplant lasts them at the most 10 years. So generally 5 to 10 years. Most of them get about 1 if they get one. But yeah, discipline and working with them with stuff like that, especially in the hospital, because you don't want them, and you can tell them it's not okay to do that here. And it's not okay to talk to your parents out here. Or this is a children's hospital. You can't cuss at the nurses. Yeah. Yeah. It depends on the severity. But most of the time you're looking at older school age or, teenagers. But, there's different, some just don't seem to have as bad a time as others. It just doesn't seem to be as severe. And I think it's just like a genetic, with that. Yeah, you have some do. Yeah. You have some. And it's longer. It used to be like early teens. This used to be something, but it's gotten better with treatment. And this is why they bring them in frequently to manage that. But because it's primarily a childhood disease, it's hard as they age into adulthood to find adult caregivers that manage it. Alright, Jackson's a 5-year-old CF patient admitted for a tune-up. Name some ways you can safely involve him in his care when hospitalized. What can we do with him? Huh? Give him tasks. What kind of tasks for CF? He can hold his nebulizer. He can pick if he wants a mask or a pipe. He can, help. You can have him, help turn stuff if you need to. You can have him choose which meds he wants first. As long as it's not the bronchodilator and the corticosteroid. FYI. Alright, So school-age kids. We got a 10-year-old with CF. She's coming in the hospital for years. She's usually happy and chatty. Now she's more withdrawn. She says she's okay. When her mom takes a break, you ask if they're anything about. She tells you other kids at school are making fun of her and she doesn't want to go back. Okay. Yeah, you want to empathize with her. You want to give her a place to talk, a safe place. You can involve child life. You can have a talk with other CF patients, and maybe they have to do like video, chats or things like that. But you can find her other patients to talk to, and find her like a support group. Online's kind of talk to some of her friends. You can talk to some of the friends at school. Maybe they just don't know what that means. So maybe you can talk to the school nurse and have them do a presentation, or there's some different things you can do with that. Okay, good. All right, here's our adolescents. So these are the ones we talk about. We're worried a lot about the differences in appearance. So if they've got a G button, if they've got a Metaport or some type of PICC line for chronic, IV infusions, they're going to be underdeveloped. They're going to be underweight. They're starting to think about their future because you're in this whole identity versus role confusion, but, they may think their future is kind of bleak, so they have them on antidepressants. They don't want their identity to include CF. So they want to, they don't want to be compliant. Then you start looking as they start moving into that whole, when we're looking at formal operations, that planning for the future and safe choices, because they're already going to be risk takers, and if they think, well, I have CF and I'm not going to live that long, it may be exacerbated. Sometimes you will even include them in planning their own funerals and things like that, because that gives them control. So, yep. Yep, I'm going to post it. I'm going to post this, yeah. Alright, Trey's a 17-year-old CF patient in his senior year of high school. He wants to go to college out of state, but his parents are nervous he won't be compliant with his care. What are some suggestions you can give the family to help Trey transition to being one responsible for his own care? Care contracts? What else? They should have been planning, but we can start getting him calling in his own refills. Maybe we need to find a pharmacy that's close that we can work with here and there that you can help. Right, you can renew stuff online. We want to find a PCP where he is, that kind of stuff. If he's going to be in the dorm, maybe talk to the people around there, and if they have an RA, resident advisor, different things like that. Do they have a family or friend or somewhere that's near there that he can have as a support person? So you want them to start, we always want self-care. So we always want to move towards whatever self-care can be done for that developmental level. Okay. So real quick, something you're going to see in PEDS is the Pediatric Early Warning Score, or PEWS. And the biggest deal with this, it's an objective tool they've developed, and basically what we're looking at is trying to catch patients before they totally decompensate and circle the drain on us. Okay, so you use a scoring system, and there's different, depending on the facility you're at, with each score, they have what you're supposed to do with it. So you either have to call the charge nurse, the resident, you have to get the resident to come to the bedside, you have to call a MET or a code team, that kind of thing. So it's very straightforward. There is a cardiac PEWS. Those of y'all that are on a cardiac unit, it has a little more. It has like gastrointestinal because it's looking at gut perfusion and some of that stuff as well. But the basic one just looks at behavior, cardiovascular, and respiratory. So are they playing inappropriate? Are they sleeping? Because if we're sleeping, we're already at a decreased state, so we're at higher risk for compromise if there's an issue. Are we irritable or are we confused? Are we pink? Is our cap refill normal? Are we tachycardic? Are we really tachycardic? Are we bradycardic? That kind of stuff. Respiratory, are you having to have a high percentage of oxygen? Are you normal? That kind of stuff. So it looks at the score, and then this has a really good chart for like a heart and respiratory rate at rest. That's good for that. And it just means how frequently you have to reassess the patient. Most of us will be doing Q4-hour PEWS if you're required to do it with your assessment at your hospital. Okay. I already talked about this. let's see. I'm gonna go through it. Y'all can look at that on your own. It just talks, I'm gonna post this so y'all can test yourself and see how you'd score them and what you'd need to do. And I'll post this too, because I want to show y'all how to get to the VSIM. Alright. Okay, so I'm gonna stop this recording.